Welcome to today's webinar, Expanding Preventive Behavioral Health Services in Schools. I'm Rachel Barron Van Cleve with the Medicaid School-Based Services Technical Assistance Center. We're excited to explore school-based prevention strategies that can be supported through Medicaid and the Children's Health Insurance Program, or CHIP. Many of us are more familiar with how Medicaid and CHIP can support treatment, so we're excited to explore prevention today. I'm joined today by my TA Center colleague, Lauren Holohan, who oversaw North Carolina's School-Based Services Program for 16 years, and Kate Guinness, a Senior Policy Advisor at CMS focusing on children's health. And we welcome guest speakers from Massachusetts and Maine. John Crocker is the Director of School Mental Health and Behavioral Services for Methuen Public Schools in Massachusetts. He also directs the Massachusetts School Mental Health Consortium. Megan Scott manages the Substance Use Prevention Program at Maine Center for Disease Control and Prevention. Penny Townsend, also of Maine CDC, coordinates school-based health centers. We are grateful they're here to share their stories. Here's what we have in store for you today. After I review the objectives, CMS's Kate Guinness will remind us why this work matters. Lauren will explain what we mean by preventive behavioral health services and their role in a multi-tiered system of supports. I'll provide a framework to understand what services can be covered by Medicaid or CHIP. And then we'll hear from our state speakers about preventive initiatives that you might implement in your school or state that can be covered by Medicaid or CHIP. John will explain how in Methuen Public Schools, every student is screened for behavioral health needs, and group therapy is available for those who need it. Megan and Penny will describe how Maine's school-based health centers are piloting screening, brief intervention, and referral to treatment, or SBIRT, for substance use. And I'll describe how Idaho's Medicaid state plan covers social-emotional skills building for some students. What if you want to provide preventive behavioral health services that are not covered by Medicaid? In the next section, we'll describe additional funding mechanisms that can support these initiatives. We may have a few minutes for questions at the end. Please submit your questions on preventive behavioral health services at any time during the webinar using the Q&A feature. What can you expect to walk away with? We hope you'll be able to describe how schools can address youth behavioral health needs through the multi-tiered system of supports, list the criteria services must meet for Medicaid coverage, provide real examples of school-based health services that can be supported by Medicaid, and explain how you could use Medicaid and CHIP funding to expand access in your school or state. We may not answer every question on your mind, but we really hope to inspire you about what's possible. And please look for us to cover more topics in future webinars. So now I'll pass it over to CMS's Kate Guinness. Kate.
Thanks, Rachel. Okay, so I appreciate everybody taking time to be here today, and really big thanks to the TAC, who have just been incredible partners to CMS and Ed in driving this work along with us. So I'm just grateful, and I'm happy to be here. I'm Kate Guinness. I'm a policy advisor on all things kids. I am a kids behavioral health clinician for the first big chunk of my career. And so this issue is particularly near and dear to me because we know that I think kids are 6 times more likely to get a behavioral health service in school as in the community. So we want to do all of the things we can do to understand how to get them services early. And not wait until they do things like end up in the emergency department or things like that. So I'm really delighted to be here. I don't need to, but for those of you, many of you who have been here before to our webinars, you know that we've been at this for a couple of years now, and really feel like we've gotten a lot done, and yet there's still a lot to be done. We appreciate all of the information that has been, I'm not going to read the timeline because you all can read it, but we appreciate everything that has kind of been propelled forward by the Bipartisan Safer Communities Act, which includes the TA Center. It includes the recently issued grants, and it includes really the capacity for us to be able to answer a lot of questions that are coming in, and where we spent time with our colleagues in Ed, as well as folks from the TA Center, grappling with sometimes really hard to answer questions. So I am delighted to be here and welcome you also from Dan and the rest of the leadership at CMS. I will, I think, pass it back now. And Rachel, I'm passing it back to you, I
That's
believe.
right. Got it.
Excellent. Thank you so much.
Yeah, thanks so much, Kate. Um, really appreciate your championing this topic for this webinar. So before we dive in, a shout out to previous TA Center webinars on behavioral health. We've covered comprehensive school mental health systems, provider billing for mental health services, and the CDC's School Mental Health Action Guide. You can find these and all past TA Center events on Medicaid.gov. And I'll turn it over to Lauren to level set on why we need preventive behavioral health services and what they can include.
Awesome. Thank you so much, Rachel. So why is it important to support youth behavioral health in schools? In a longitudinal study of over 36,000 middle and high school students, school connectedness was found to be the strongest protective factor against substance use, school absenteeism, early sexual initiation, and risk of unintentional injury. Schools play a critical role in supporting youth with behavioral health concerns. These services are led by school social workers, psychologists, counselors, nurses, occupational therapists, and others. There's a wide range of student needs and potential services, and one framework to match those needs to supports is the multi-tier system of support, or MTSS. MTSS is a comprehensive continuum of evidence-based systemic practices to support a rapid response to student needs, with regular observation to facilitate data-based educational decision-making. MTSS organizes intensification of support in curriculum, instruction, and environment based on student need. Intensification can happen in terms of the frequency and duration of supports and services, the size and homogeneity of the intervention group, proximity of service delivery to the general education setting, and then the specialized training required to deliver the intervention. MTSS features include screening, progress monitoring, a multi-level prevention system, and database decision-making. The MTSS framework helps schools organize staff providing behavioral health and other services for general and special education students alike. So we want to be clear here at the outset. What I'm going to share is an overview of what LEAs and schools may be organizing in terms of behavioral health supports. This doesn't in any way suggest that these services are currently covered in your Medicaid state plan. So SEA and LEA stakeholders really need to communicate the array of what's being offered to their state Medicaid agency partners to see what is or potentially could be reimbursed. So schools generally organize 3 tiers or layers of behavioral health supports under an MTSS framework. The first layer of support includes universal or primary prevention activities for all students. Universal supports promote protective factors and healthy behaviors and reduce those risk factors that can lead to the development of a disorder. Examples of universal initiatives for all students might include behavioral health screening, suicide prevention, youth mental health first aid, anonymous reporting applications for students, or social and emotional learning. If students aren't responding as expected to those universal supports, the next layer, targeted or secondary activities, provide prevention or early intervention for students who are experiencing mild mental, behavioral, and functional challenges. School staff might determine risk through needs assessments, behavioral health screening, or team conversations. Examples of targeted services include peer-to-peer supports, short-term small group therapy, or brief individualized interventions for students who don't have a diagnosis or aren't covered under a plan of care. Targeted interventions are often delivered by school staff that are not qualified behavioral health care providers. The most intensive layer of support includes individualized treatment for students experiencing significant behavioral health challenges or functional impairment. Some examples of intensive supports in schools include individualized counseling, reentry supports for students returning after a psychiatric hospitalization, or intensive applied behavioral analysis interventions for students with autism. Intensive interventions are often delivered by school staff who are qualified behavioral health care providers. And it's important to understand that if students aren't responding to a given layer of services and require more intensive supports, the more intensive interventions don't supplant, but instead supplement the previous supports, which is to say students don't so much pass from one tier to the next, but instead accumulate supports and services until they begin to demonstrate improvement or at least reduced risk. So this webinar is really going to focus on the Medicaid and CHIP strategies to fund universal and some of those targeted services in schools. And before we dive into the state spotlights, we'd like to hear from you in a couple of polling questions. These two questions are really similar, so pay attention to the details. The first is, what behavioral health services do you currently offer in your school or state? And we're going to give you a minute to check all the services that apply. If your state offers behavioral health services that don't show up on this list, select other, and you can put those services and describe those in the Q&A box.
Yeah.
And it looks like social emotional learning, individualized or individual or group therapy, and positive behavior supports and interventions kind of came out there on top in terms of the strategies you're using. So let's go ahead and go to the next question. As I mentioned, it's very similar, but this is more aspirational. What behavioral health services would you like to offer in the future in your school or state? So you're not necessarily offering those now, but what would you like to see added to the array of services you offer? Looks like behavioral health screening, expert, substance use prevention, group substance use prevention, are kind of heading that list. So this kind of, I think, sets us up nicely for handing it back over to Rachel and setting us up for what those services are that Medicaid might cover. Thanks, Rachel.
Thanks so much, Lauren. And we do have speakers on some of those services that you want to cover, so that's exciting. So some, but not all of the services Lauren described can be covered by Medicaid. How do you know what can be covered? We're going to talk about direct services and administrative services. Direct services are the services healthcare providers provide directly to students. Direct services must meet 3 criteria for Medicaid coverage. They must be delivered by a Medicaid enrolled provider to a Medicaid enrolled student and covered under the Medicaid state plan or Section 1905A of the Social Security Act. Sometimes it's tricky to know what can be covered. So here are a couple examples of how these criteria can be applied. Social emotional learning delivered by a classroom teacher is not covered by Medicaid. However, a skill building group can be covered by Medicaid if delivered by a Medicaid provider to Medicaid students and covered under the Medicaid state plan. The skills building group can include both Medicaid enrolled and non-Medicaid enrolled students, and Medicaid reimbursement could be available for the Medicaid enrolled students. As a second example, general tobacco use prevention education is not covered by Medicaid. However, tobacco cessation counseling can be covered if it's delivered by a Medicaid provider to Medicaid enrolled students who have been identified as tobacco users, and if it's covered under the state plan. One of the key distinctions here is whether a service is clinical. General tobacco education is not clinical, but tobacco cessation support is. Another example would be substance use education. General substance use education is not clinical, but later today we'll discuss a clinical counterpart that can be covered by Medicaid called screening, brief intervention, and referral to treatment. A few words about Medicaid benefits. In Medicaid, there is not actually any benefit called behavioral health services, but behavioral health is often covered under other benefit categories. Preventive behavioral health services, such as screening for depression or anxiety, could be covered in your Medicaid state plan under the category of preventive services. Individual or group counseling could be covered under rehabilitative services. Testing by a licensed psychologist could be covered under other licensed practitioner services. Many services could be covered under more than one benefit category, and every state does it a little bit differently. The benefit categories of preventive, rehabilitative, and other licensed practitioner services are defined in Section 1905A of the Social Security Act. Here's the thing. Regardless of what is written in your Medicaid state plan, every state is required to cover early and periodic screening, diagnosis, and treatment, or EPSDT. This benefit entitles most Medicaid enrolled children and adolescents to any medically necessary service or treatment listed in Section 1905A of the Social Security Act. So whether or not your state plan includes preventive or rehabilitative services, if a Medicaid enrolled child needs behavioral health services, they're likely covered under EPSDT. And here's the next thing. For preventive behavioral health services under EPSDT, a specific behavioral health diagnosis is not required. You can read the details in CMS's recent state health official letter on EPSDT. States must cover services to address early signs or symptoms of concern with or without a diagnosis. We'll talk a little bit later, talk a little bit today about the mechanics of claiming for Medicaid reimbursement without a formal diagnosis. So now we're moving from direct services to administrative expenses. And bear with me, we're almost through the weeds of Medicaid claiming. LEAs can claim reimbursement for Medicaid administrative activities that are in direct support of the Medicaid program. For example, if the school helps connect a Medicaid enrolled student to Medicaid covered treatment for anxiety or depression, the time for that referral can be claimed as a Medicaid administrative expense. This slide shows several requirements for Medicaid administrative claiming. For example, the LEA, which is the school or the school district, the local education agency, and the State Medicaid Agency will need an interagency agreement, and only allowable expenses can be claimed. Whether or not you follow the intricacies of Medicaid benefits and claiming, if you're here today, you probably have a role to play to bring services to kids. We're about to hear from our state speakers. As you listen to the initiatives, think about what is the role for the local education agency or LEA, the state education agency or SEA, and state Medicaid agency or SMA. The LEAs, schools, and school districts are on the front line of understanding, assessing, and responding to student needs. They might identify the need for new services or provider types. The SMA maintains the Medicaid and CHIP state plans. They can identify Medicaid benefits that can cover the services and any changes that might be needed to provider qualifications or allowable procedure codes. The state education agency can be a liaison between the LEA and the SMA. They could list the services and providers needed in schools and sit down with the SMA to map these to the Medicaid state plan. And they can partner with the SMA to offer training and technical assistance. So you all have a role. And now for our state spotlights. We'll start with initiatives that can be covered by Medicaid. Our speakers will focus on implementation, and I'll highlight how Medicaid claiming can work. Welcome, John Crocker.
Hey there.
Great. So we're excited to hear about behavioral health screening and group therapy in Methuen Public Schools. And let's start with behavioral health screening. How did you decide to introduce behavioral health screening in Methuen Public Schools, and can you tell us how it works?
Absolutely. So we recognize that we were really responding to crisis and diagnosis far more often than we were engaging in proactive and preventative identification of students. We were incredibly lucky to be a part of the National Quality Initiative COIN, which is the Collaborative for Improvement Innovation Network for Comprehensive School Mental Health. It's the longest acronym ever, but it was an opportunity for us to really look at the development of a comprehensive school mental health system. And one of the components of that system is universal screening. So how do we find students in a more proactive and preventative manner so that we can actually address problems as they're emerging instead of just reacting to crisis and diagnosis? So our decision making was one of an investment in prevention. How does it work? Well, we deploy screening universally across all grades, so K-12, using a variety of different measures. For our youngest students, these measures are incredibly simple and accessible, developmentally matched. I would say that the screening in grades 5 through 12 starts to get into more problem-specific areas: anxiety, depression, post-traumatic stress, substance use, social-emotional competence. It is the case that every student on a periodic basis gets a screen. We typically do fall and spring. Those results are then fed to our school mental health staff, so school counselors, school, psychologists, school, social workers, and we vet those data and pull students in for really clinical interviews so that we can determine if they are eligible for an intervention. That could be group therapy, individual therapy, or referral to a community-based agency or some of our programmatic services. These data have been instrumental in understanding not only the specific needs of individual students and inform referral, but also understanding our aggregate population's needs, which allows for us to make some decisions at the systems level.
That's awesome, John. I love that story. I love that you've got screening in place. Do you have any tips for school districts that are going to start implementing behavioral health screening?
Absolutely. I think that screening is not the kind of implementation undertaking that you want to do all at once. I would really adopt a continuous quality improvement approach whereby you are instituting small changes, enacting small tests of change so that you can get it right the first time, make your errors when your implementation is small stakes, and then scale it up and adjust your practices as you bring the practice to scale. I have said this an unbelievable amount of times. You start with one student, one measure, one day, and really introduce this practice to staff so that they can really begin the process of understanding the best practices for implementing screening. Get some exposure to different tools, understand the process, and then confidently move forward with scaling up the implementation to maybe 5 students and maybe a class, grade, school, district. And using that kind of an approach ensures that you are accounting for changes that are requisite to bringing the practice to scale.
Thanks so much.
One other piece, Rachel, I would just say that the order of operations in terms of what you select for screeners matters too. I would worry about screening for trauma to start. I would say that, please pick a measure that is going to land well in your community so that you can show proof of concept and then move on to topics that are a little more stigmatized. I think that will allow for you to ultimately have a little bit more buy-in from stakeholders around the utility of screening so that you can get into more nuanced screening that is a little more technical and requires a little more thoughtful planning.
That makes a lot of sense. So behavioral health screenings are included in the EPSDT benefit, and provider time for screening can be captured in a random moment time study. But we know from your previous webinar with us that Methuen isn't actually claiming for direct services yet because of a couple problems. One, the money would go to the local government, not the schools. And second, many of your providers aren't eligible for Medicaid enrollment under current state policy. So what are your plans to take action on these issues?
I know that there is work being undertaken at the state level to really adopt the CMS guidance that's being passed down to allow for our Department of Elementary and Secondary Education licensed staff to be able to engage in school-based Medicaid claiming. I feel like that is work that is incredibly important as a piece of the puzzle because at this time, the providers that I have in school are doing the work of providing these claimable services. However, the license doesn't line up such that they can engage in that. So I think there's some statewide work to really consider the changes that or the allowable moves that CMS has passed down as guidance. I think that's step one. Step two is this is a state that needs to, and I would say this is true of the field, that documentation practices and really engaging in progress monitoring, treatment planning, identification of presenting concerns is a piece that we have to raise the field around this topic for sure. That's a topic in Methuen that I'm actually not worried about. This is just best practice that we've leaned into. Every student receiving a tier 2, tier 3 service is engaged in measurement-based care where we are providing regular screenings associated with the presenting concerns. There's a treatment plan, there's a goal, we're identifying the problem area. The third piece is the piece that I would have to kind of take action with, and that is actually engaging in some degree of drafting an MOU with our city. to ultimately say, we are committed to engaging in the school-based Medicaid claiming process. However, we are not going to start engaging in this process until we have an agreement that some of the funding will be funneled to the schools. I think that it represents a degree of negotiation that will be necessary, but one where both parties can win out in this situation. But I do think we have to a little bit use our position as the ones who will engage in the practice to our advantage.
Thanks. And that ties in nicely. A little later, we're going to talk about strategies to get that money back into schools. We received this question during webinar registration. Do you receive parental consent for screening? And if so, how?
We do. And really, we're talking about two methods to secure consent. Active consent, basically asking parents, is it okay if we engage in the screening, and getting written consent to do so. We used that in the beginning of our screening implementation when it was a small set of students because it really didn't represent any kind of implementation barrier. But once you bring this to scale, I would strongly recommend passive consent with opt-out. And that is essentially telling parents we're going to engage in universal screening. Please tell us not to. Here are the opt-out procedures, and allowing for parents to opt out if they feel it's inappropriate or if they don't want to engage in that practice. We allow students to opt out as well. We're not trying to force the issue with anyone. We're simply trying to provide an opportunity whereby students can access screening with ease, and also trying to create parity between behavioral health and physical health screening. We do a lot of passive consent with opt-out for physical health screening. We want to elevate behavioral and mental health screening to the same level of importance.
Very useful tips. Thank you. A few more minutes with John, but we want to hear about the behavioral health group therapy program. So can you tell us about your group therapy program in Methuen Public Schools?
Absolutely. These two topics are tied together well because after we started screening, we recognized that our current approach to providing behavioral health services in schools was not going to be adequate to get to all of the needs that were identified. So we really leaned into the development of a group therapy program that would efficiently and still very effectively provide care to students who were identified through screening. We are talking about true group therapy, so in vivo processing. There is a psychoeducational component, but we are doing real cognitive behavioral therapy, 8 to 10 weeks, 8 to 10 students, focusing on a very specific presenting concern. This has allowed for us to be to attend to a greater population of students in an efficient manner, and also enrolling students in a service in a more proactive and preventative manner, because I think that there are some natural vetting and sorting practices that occur when we're enrolling a student in individual therapy. And we can back that out a little bit when we talk about group therapy and really look at mild and moderate concerns as being an eligible opportunity to enroll in a group service. So we don't have to be as picky, and we can service a larger set of students in a more preventative manner.
Yeah, you said preventive and mild or moderate. So just to put a fine point on it, is a formal diagnosis required for students to participate in the group therapy program?
Absolutely not. Yeah. Yeah, we don't want it to be the case that we have to wait for diagnosis and crisis to intervene on behalf of students with needs. And I also think it does represent the case that not all of our families have the means by which to secure a diagnosis, and some of the risk factors associated with or some of the disproportionate outcomes associated with some families and students that are keeping them from being able to access medical services to secure that diagnosis. We don't want that to be a factor in terms of them accessing care. I also think it's simply the case that we want to provide mental and behavioral health services to all students. We do not reserve this for special education only. It's important that we provide care to everyone.
Yeah. So you don't have a diagnosis, but how do you document medical necessity?
Right. So you can absolutely identify the presenting concern without having a diagnosis. And I think that there's looking at an ICD-10 code and being able to understand, we are treating these students for anxiety and depression because that is what we screen them in for using our universal screening process. So we're going to weigh that the ICD-10 codes, the appropriately matched codes that line up with anxiety and depression. So it is 100% the case that we're not diagnosing, but we are referencing the presenting concerns that we are treating students for. And I feel like that is an act that allows for us to thoughtfully plan for the intervention and also document what the intervention's about and aimed at.
Awesome. So I'm just going to say that back in what I'm hearing, that the screening results can demonstrate the need, and that um, and then I want to explain a little bit about the Medicaid coverage, that this group therapy for children and adolescents is covered by Medicaid because of EPSDT requirements. The formal behavioral health diagnosis is not required for preventive services under EPSDT. And a lot of people are confused about, then what diagnosis do I write on a Medicaid claim? You don't have to have a formal diagnosis to write down the ICD-10 code that corresponds to the depression or the anxiety, the need being addressed. And Massachusetts has also issued guidance for managed care outside the school setting that Z codes can also be used to indicate the need for preventive behavioral health services. Z codes are ICD-10 diagnostic codes that don't correspond to diseases, and they're another strategy states can use to facilitate submission of behavioral health claims without a diagnosis. So John, thank you so much. I think we're going to stop there. If we have more time at Q&A, we may send you a couple more, bring up a couple more questions. A treasure of implementation, experience, and tips. So thanks so much.
Thanks, Rachel. I appreciate it.
Yeah. So now we welcome Megan Scott and Penny Townsend of Maine CDC, and I'll give them a moment to get their cameras on. So Megan, Maine is piloting an early intervention for substance use disorders called Screening, Brief Intervention, and Referral to Treatment, or SBIRT. Can you explain what SBIRT is and why Maine decided to pilot it in schools?
Sure. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, defines SBIRT as a comprehensive and integrated public health approach to the delivery of early identification, intervention, and treatment services for individuals experiencing a substance use disorder or for those who might have an elevated risk of developing a substance use disorder. So in Maine, a few years ago, we recognized a gap in our prevention work. And ultimately our goal, we focus on primary prevention on my team. And so ultimately our goal with adolescents is to delay the onset of use as long as possible. But our youth survey data is showing that, youth are using for a variety of reasons and they're using younger. So we decided to explore opportunities for expanding preventive screenings in school-based settings as a tool to help in identifying risky use patterns early. So in collaboration with multiple offices in Maine's Department of Health and Human Services and the Department of Education, we developed a plan which included hiring a project coordinator who unfortunately couldn't be here today to talk about this. So I'm filling in for her, and conducting an assessment to gain a better understanding of current SBIRT implementation throughout the state. So as a result of that, improved mechanisms for conducting preventive screenings with adequate, accessible follow-up were identified as the priorities for us. School-based settings emerged as a preferred location for this intervention due in part to the lack of accessible transportation and primary care services in the state. We have a lot of rural areas in Maine. And because the relationships cultivated by school-based health centers, the providers are crucial in boosting those linkages between adolescent and potential resources for making healthy choices. And that's bolstered by the integration with a student's daily environment.
So the school-based health centers were determined to be a great spot to pilot SBIRT for youth. Penny, we understand that in Maine, many schools have these school-based health centers. Could you tell us more about them?
Sure. There are currently about 20 school-based health centers here in Maine that receive some level of state funding. And then there are about an additional 9 that receive technical assistance and have a variety of other funding sources. And this number continues to grow. But in Maine, a school-based health center is defined by a school that has a consistent, regular availability in school of both clinical and behavioral health care at a set number of hours based on their population, because we have schools of all sizes here in Maine.
And I understand that the school-based health centers are a model where community providers co-locate at schools rather than the LEA enrolling as a Medicaid provider.
Correct. Most of our school-based health centers do partner. They don't necessarily typically enroll as a Medicaid partner. They do partner with a healthcare facility of some sort. And they do some schools do offer services such as occupational therapy or physical therapy or speech therapy with Medicaid, but that's to the targeted people that usually special services, not to every student.
And then I understand that some of Maine's school-based health center, well, as you just said, some of them are sponsored by federally qualified health centers or primary care practice partners. The sponsors can provide systems for the school-based health centers to take on the administrative task of Medicaid claiming, which would reduce the burden for schools, and the community partner can receive the Medicaid reimbursement. So this arrangement can help sustain the service delivery. Does that sound right?
Yes, it is a benefit for the to work with a federally qualified health center or actually a health center in general where they actually do all of the billing for the school. The school just provides the in-kind space. But we do have 2 schools in Maine that actually do just get the funding and they hire their own nurse practitioner and they don't necessarily bill. So it's almost like an in-kind service for their students.
Great. So going back to Megan and Espert, I understand you had a choice of screening tools. Which did you choose and why?
Our coordinator, she reviewed them all, and there are many evidence-based tools that are approved for use with adolescents, but the CRAFT is really considered the gold standard for young people between the ages of 12 and 18, which is our target population for the pilot. And additionally, we opted to use the verbal CRAFT 2.1 plus N because that explores commercial tobacco and nicotine use in vaping. And more actively engages both the student and the provider in the SBIRT process, allowing for the provider to roll directly into a brief intervention discussion with the student based on the screening result.
Great. I hope that's helpful for some others who may be deciding what screening tool to use. How has the program grown over the first year? And I understand you're in the second year now.
Yep. So we wrapped up the first year in June with 3 schools. And started the second year. Those same 3 schools decided to stay on for another year, and then we added an additional 3 schools. So we're up to 6. For the first year, the 3 participating sites screened a total of 386 students, and an additional 21 students who were eligible for the screening opted out during the project's verbal assent process. But the goal of this project was really to screen all students enrolled in the school-based health center during their annual well visit, which 2 out of the 3 sites were able to do. Some of the notable outcomes for the year, 37.5% of those 386 students received a brief intervention. 50 students were referred to follow-up treatment, which in most cases consisted of a follow-up visit with the school-based health center provider or to an external outpatient provider. And a lot of times that was to a tobacco vaping cessation program called My Life, My Quit. And what we also think is exciting from a primary prevention lens is over 86% of the participants screened were not using substances, but they all received positive reinforcement for their non-use. All sites grew their enrollment. 1 school updated their substance use policy from a 0 tolerance to a more restrictive approach. To a more restorative approach. And the project really provided an opportunity for positive relationship building with students, hopefully impacting that protective factor of connection to school and care in adults. So, we have the screening, but we also have some of these other, exciting things that happened in addition to it.
That's really exciting. I'd love to hear how the screening is rippling out into other positive effects. How is Maine funding the SBIRT pilot? Can you explain where the money is coming from and how the school-based health centers are using it?
Sure. So, as we've discussed, school-based health centers are supported by Medicaid, to some extent. But in year 1 of this pilot, funding came from kind of a unique source. It's called Maine's Opioid Prevention and Treatment Fund, which is made up of fees that the pharmaceutical companies pay to the state so that they can distribute opioids. So that's what we used the first year. And then for year 2, we're using some of our remaining American Rescue Plan or ARPA funds. And Maine has done a good job protecting our tobacco settlement agreement funds and using that for public health. So we are tapping into some of those to support the sites as well. The sites are receiving between $50,000 and $75,000 per year, and kind of using those funds to support the startup, the protocol development, and then that additional staff capacity that's needed to do this, and comprehensively.
Awesome. Thank you. So this question is for Penny. How can providers like school-based health centers claim Medicaid reimbursement for SBIRT?
So Maine's primary care practice partners are eligible to receive an enhanced reimbursement for SBIRT, and it's really just kind of it just is one of the billing. There's like a billing code for it. Maybe some of the barriers of claiming it. There is in Maine we have a expanded Maine minor right protection around a student's ability to consent to mental health and substance use treatment services independently of a parent guardian. So students in the state of Maine can consent to have those treatments done without parental permission. And in that case, they don't bill insurance for that. A lot of times that's what they're actually using this grant funding for, is to kind of cover some of the cost. Some constraints also associated with providing appropriate follow-up for student based on a screening result, and more, it just requires more time that's allotted in a well visit. So sometimes that time can be an issue. But particular care and concern is placed on providers when a student discloses substance use and also identifies that disclosure to a parent and guardian might put them in harm's way. So there are a lot of, kind of nuances around that issue.
Yeah. So I feel like this is a really important sort of policy issue or implementation issue to dig into that we don't have to discuss further today, but just to sort of bookmark how to reconcile the billing with the privacy concerns to be able to support and sustain SBIRT. And I understand that there's a variety of ways a school-based health center might choose to code or claim for SBIRT, that there's some flexibility. Feel free to add. Yeah.
So most all school-based health centers are set up a little bit differently and bill a little bit differently, but most wrap it into a general well visit. So, when you go and do your well visit, it's a chance for them to actually all roll out some of those screenings, such as the SBIRT, as well as RAPS, which is the Rapid Assessment for Adolescent Preventative Services. And so going through those health risk assessments during that well visit really can establish, what's needed. And then it allows for the provider to bill even more services or other services that are necessary. And then in some instances where a student might screen positive on SBIRT, providers even have the ability to add that on as a rented service to the well visit and even bring them back for follow-up visits.
That's great. Hope this is getting folks' wheels turning about how they can claim for SBIRT. So in addition to the Medicaid claiming, Maine is currently using some of these other funding sources. What options is Maine considering to sustain its SBIRT initiative when these pilot funds end?
That is the question. We're, since day one, we've been thinking about sustainability and how, we're going to achieve that. We're still kind of working on a plan, but, part of our motivation for sharing the results and presenting on this is so that, especially within the state of Maine, we can, we know that a lot of the state departments care about this. And so, once they can see how successful the pilot is, hopefully we can all kind of collectively put our heads together and think about a way that, other departments can maybe contribute to this. Other things that we've thought about, that we dream about, is potentially designating a portion of Maine's alcohol or cannabis tax revenue to this. Maybe utilizing some additional tobacco settlement funds, and then, any federal opportunities. Sometimes SAMHSA has an SBIRT grant out and things like that. So we're always kind of looking for that sustainable funding. Also at the same time conducting a cost analysis to determine really how much of each of the currently funded school-based health centers, sorry, I was going with the acronym, would need, independent of potential reimbursements, to continue this work to fidelity. Also, I don't, Penny didn't mention it, but, our school-based health centers are also looking for sustainable funding as well. So, so it is, something that we're constantly thinking about and trying to be creative in how we sustain it.
Yeah, thanks for sharing your ideas. So in general, states can cover SBIRT as a Medicaid state plan service. It is covered under EPSDT requirements, and 1905A benefits like preventive and rehabilitative services. States would set up procedure codes and rates. And this Maine SBIRT pilot takes place at school-based health centers in another state where the LEA provided the service and claimed the expense, and where the state used a reconciled cost payment methodology. Providers' time for screening and follow-up could be included in the time study, in the random moment time study, and allocated to Medicaid in that way. So that might be a different claiming model. So finally, Megan and Penny, what tips do you have for others who are considering an SBIRT initiative for their school or state? And we just have about 2 more minutes.
I don't know if Penny, if you want to do this, or I'm happy to take this.
So I think the most important thing is to ensure that there's a dedicated point person to support the project at the state level. There really is a lot of coordination, as well as identifying and recruiting a program champion at each participating site. So having somebody at the state level and then having that champion in each school really helps the program go much smoother. Also ensure that pilot sites are giving guidance through scripts, best practice workflows, technical assistance, just regular communication to maintain fidelity and buy-in in the project. And that could even be just regular emails, Zoom calls, just check-ins. It has been super helpful. It would be nice to also identify a clear policy at the school-based health center level that outlines the parameters for confidential visits with students, given that there are expanded Maine minors' rights protections for student consent. And again, that may be different, whatever state that you are in. But if not federally funded, also it's nice to ensure that appropriate steps are taken to adhere to ethical practices for adolescents. So just making sure that you're pursuing and receiving institutional review, board approval, vetting, provider licensure, just making sure all of those things are in order. The flexibility is nice. So I think it's nice to allow flexibility in the program's administration, especially around what treatment might look like for a student, because it just could be so different depending on what area you're in. As able, is also nice to provide funding to support expanded behavioral health staffing hours and follow-up visits beyond the time allotted for a traditional well visit. When you get these students in a room answering the craft or some of these tools, they really do kind of share their whole life story. And sometimes it is nice to make sure that you have those resources available to them after that.
Yeah. Thanks so much. It sounds like you've had a wealth of experience. And I imagine some of our audience members might want to reach out to you. And Steph Tucker, who's not here, also said she welcomes inquiries, would be happy to help
Rachel,
answer questions for other states. Yes.
before we let Maine go, Megan, can you repeat the name of the screening tool y'all are using with your SBIRT work?
Sure, it's called the CRAFT. It is CRAFT 2.1 plus N. There we go. There's 2 F's. CRAFFT 2.1 plus N.
Awesome. Thank you so much.
Thanks. Okay. So thank you so much, Megan and Penny. We're shifting now from Maine to Idaho and to social emotional skills building as our final example today of a service that can be covered by Medicaid. A lot of social emotional learning is not covered by Medicaid, but Idaho's example checks all of the boxes we discussed earlier: Medicaid enrolled providers, Medicaid enrolled students, and a service covered in the Medicaid state plan. In Idaho, students with an IEP and serious emotional disturbance are eligible for a rehabilitative skills building service. Medicaid enrolled providers help Medicaid enrolled students develop behavior control, communication skills, coping skills, and others. And LEAs claim for this and other school-based services on a fee-for-service basis. So far, we've discussed Medicaid-covered services, but I'm excited to raise awareness of 2 additional funding mechanisms for preventive services. You may or may not have heard that the Children's Health Insurance Program, or CHIP, can fund health services initiatives. Every state can spend up to 10% of its CHIP funding on CHIP administration, but if the full 10% isn't used for administration, the rest can go to an initiative to improve the health of low-income children and youth under age 19. Note that CHIP health services initiatives, or HSIs, can include students who are not eligible for Medicaid or CHIP, and services that are not normally covered by Medicaid or CHIP, as long as they improve the health of low-income children and youth and are approved by CMS. Whether or not your school participates in Medicaid claiming, CHIP HSIs can be a tool in your toolbox for preventive services. For example, in Missouri, CHIP HSIs support local public health agency initiatives for children. Local public health agencies come into schools and other settings and provide health education, screenings, diagnosis, and referrals. If a state is interested in pursuing a CHIP HSI, it can apply to CMS to amend its CHIP state plan. We also want to raise awareness of opportunities to reinvest Medicaid reimbursement in preventive services. Colorado is a state that uses a reconciled cost methodology based on certified public expenditures, so the state has flexibility about how it spends the federal Medicaid reimbursement. CMS encourages states like Colorado to return funds to local school districts. When a school district does get the money, it can be reinvested to expand school-wide prevention programs, not limited to Medicaid-enrolled students. Depending on your state, you might need legislation to direct funds to LEAs or behavioral health programs. Colorado passed a law requiring each LEA to develop a 5-year local services plan to reinvest Medicaid reimbursement dollars into student health. The community gives input on the services their students need. During the 2021-2022 school year, Colorado invested almost $17 million of their Medicaid reimbursement into mental health and well-being activities for students and staff. And the funding also supports school-based providers. And with that, I'll turn it over to Lauren to facilitate a couple questions.
Yeah, thank you. One question for John is there's some interest in knowing about the type of electronic record system that you're using to house your screening results. And I guess really any further documentation as students receive supports.
Yeah, there's an influx of EHRs and behavioral health platforms that schools are considering. We started this 10 years ago, so we've been leveraging some tech locally, and by that I mean Google tools. It is not anything fancy, but we have a Google business agreement, so the data sits on our servers, and we feel very comfortable with the data security. But it does not have to be a very fancy platform to leverage this practice and to get screening off the ground. I do think that there are some benefits to looking at an EHR or a behavioral health platform that can deploy screening efficiently and sort results and direct those results to providers efficiently, supporting referral. But it does not have to be that complicated. The reality is that we've supported screening across Massachusetts through the consortium with dozens of districts using Google tools. It does not have to be more complicated than that.
Thanks. That's helpful. And I think for either Massachusetts or Maine, a question that we got through registration, can you talk a little bit about how you're partnering with families once kids are sort of have been moved into your system in terms of behavioral health supports?
I'll let Penny take that one if she can.
Yeah, so because of the context of the confidentiality, it's really kind of on an individual basis. We try to include parents as much as possible, but then again, we also are a safe place for students if that's not possible. So I would say a combination of both.
I'll throw in there that we really do try to engage families as much as possible, especially with our youngest students, because we know that the intercession work that has to be done to really leverage the full benefit of these services is going to require some facilitation by families. That being said, students are in the driver's seat in terms of what they want to share, and we do strongly adhere to confidentiality practices. That being said, that doesn't mean that we can't leverage the family connection if the student is open to it. So it is the case that it's a better outcome most of the time when we have a family that is supportive and will facilitate some of that work between sessions.
Great. Thank you all so much. And Rachel, I'm going to hand it back to you to wrap us up.
Okay, thanks, Lauren. If you have other questions that we did not get to today, and I'm sure you do, please email them to that address. Okay, thanks. So in conclusion, if you want to expand preventive behavioral health services in your school or state, consider how Medicaid and CHIP can help. Medicaid and CHIP can cover preventive services like screening, group counseling, or skills building when they're provided by a Medicaid enrolled provider to Medicaid enrolled students and covered in your Medicaid state plan. CHIP Health Services initiatives can fund preventive services for all low-income students, and consider whether your state can reinvest Medicaid reimbursement in preventive services. Watch your inbox and the SBS tax site on Medicaid.gov for upcoming events. Today we talked about preventive services. Come back in January for more lessons learned about implementing mental health initiatives in schools. And the slides, Q&A, and a recording of today's presentation will be made available on the Medicaid.gov website. Thank you so much for joining us today.